Hi, everyone. My name is Marcus Carden. I'm a assistant professor of pediatric and adult hematology here at UNC and currently direct the PEDS sickle program. I am originally from Eastern North Carolina in Greenville. I went to the North Carolina School of Science and Math in Durham for high school. Went here to UNC for undergrad, Brody School of Medicine for med school back home in Greenville. Completed a combined internal medicine pediatric residency training up at VCU in Richmond, Virginia. And it was there that I became interested uh, in sickle cell disease. And so pursued fellowship training, clinical and research fellowship training down at Emory in Georgia Tech in Atlanta, where I completed a 3-year pediatric hemonc fellowship and 1-year adult hematology fellowship, both at Emory. And then decided to come back up here in discussions with my wife in terms of where we would, want to go. She was following me for about 9 years of training, and we, both have family here in North Carolina, and so came here in 2018. So thank you to the organizers and everyone for giving me this opportunity to talk about sickle cell disease. I'll talk a little bit about the history and pathophysiology of sickle cell, and then go into emerging therapies and FDA-approved therapies for sickle cell. It's a really exciting time in sickle cell disease. People are calling it kind of the renaissance of sickle cell with all the drugs that are coming out and being trialed. The only relevant disclosure I have, I'm going to talk about a drug called voxelotor that was recently approved by the FDA for sickle cell, and I sit on advisory board for the company that has developed that drug. So here are the objectives. Again, review history of sickle cell, briefly go over the pathophysiology, and then talk about emerging therapies. Just touch on bone marrow transplant and gene therapy, since there's a lot of that being presented in the media, and it's an exciting time for gene therapy. But really concentrate on the recent FDA-approved drugs. So a little bit of history. So the first description of sickle cell disease was in the literature back in 1910 by a physician, James Herrick, who was in Chicago, who described these unusual blood findings on a peripheral smear of actually a gentleman who was a dental student from the West Indies. Walter Clement Noel was his name, and he was in Chicago going to dental school. And had showed up at the hospital with pain and other complications. And as you can see here, Dr. Herrick writes, I report some details that may seem non-essential, thinking that if a similar blood condition is found in some other case, a comparison of clinical conditions may help in solving the problem. Now, obviously, over hundreds to thousands of years, sickle cell disease has been around because of the genetic mutation that we know is associated with it. But this, again, is the first time it was ever described in literature. So Dr. Todd Savitt, who's actually a medical historian and ethicist down at Brody School of Medicine, where I did my med school training, spent years actually investigating the story of Walter Clement Noel. Went to Chicago to find, documentation, the original documentation. Spent time actually in the West Indies, talking to ancestors of Walter Clement Noel. And really wrote up this really amazing story in JAMA in 1989 about Walter Clement Noel. And so for those who, we're kind of in the age of EMR now, but most of us remember writing on paper in charts. And so this was something that Dr. Savitt found in Chicago, the original really CBC lab-based values on patient Noel. And you can see, they looked at the blood smear and counted the number of white cells, red cells. You can see down in the corner, so, malaria was very common. So this was something that was on the paper when they were doing the medical record for patients. This patient, he did not have malaria at the time, but just interesting historically to throw that in there. But what he did find too is that, Dr. Herrick drew these sickle red cells and put them in the original chart. So the first documentation of seeing sickle cells on the peripheral blood smear that we know of. Now move forward 39 years, and we're in the age of Linus Pauling, who went on to get 2 Nobel Prizes, one for medicine and one for peace. But this is from Science and published in 1949, the first description of sickle cell disease as a molecular disease. So for those that don't know, sickle cell was the first molecular disease ever described. And he says, the erythrocytes of certain individuals possess the capacity to undergo reversible changes to partial pressure of oxygen. When oxygen pressure is lowered, these cells change their form and from the normal biconcave red cell disc to crescent holly wreath forms. And so this process is known as sickling. So now we know sickle cell disease is kind of seen throughout the world, primarily in regions where malaria is endemic. And so this is a heat map of sickle cell trait. And as you can see, the majority of trait is seen in sub-Saharan Africa, where there's lots of malaria, as well as the Mediterranean and Indian subcontinent. So lots of sickle cell disease are seen in these areas. And then because of the transatlantic slave trade, we see lots of trade in Brazil, northern part of South America, as well as regions of North America. So sickle cell trait, the highest density of sickle cell trait in the United States can be found in Florida, New York, California, and Texas. So just another piece of information. So in the United States, we have about 100,000 patients with sickle cell disease. We have maybe 5,000 patients here in North Carolina spread out among 6 regional sickle cell centers. And then we have about 30 newborns a year that come here to UNC with a new diagnosis of sickle cell. So again, 100,000 in the United States, whereas in sub-Saharan Africa and Nigeria, 100,000 babies are born each year. And the median life expectancy there is about 5 years old because of the lack of immunizations and penicillin prophylaxis, which we have access to. And depending on what you read, the median life expectancy here in the United States is about 50 to 60 years old. So just, to take it back just a little bit, sickle cell disease is inherited or comes about from inheritance of sickle cell trait from parents who have sickle cell trait. And so this is kind of an example of a Punnett square. We have 2 parents who have sickle cell trait. And so the probability of having a child with sickle cell disease is going to be 25%. Versus having a child with sickle cell trait is 50%, and then having a quote normal child without trait or disease is 25%, and that's with every birth. So sickle cell disease, as most of us probably know on the call, is a hematology disorder. So hematology, as we're aware of, is a study of blood-forming organs, and blood diseases. This is just a cartoon of the bone marrow, right? Areas of the bone marrow that produce blood cells. So the bone marrow is the blood cell making factory in the body. And really it's the red marrow that makes it. And so in children, every bone in the body really is participating in making those blood cells, compared to when we become adults. It's only the pelvis region, spine region that's contributing, because the other parts turn into yellow marrow. This is important in sickle cell disease because we see something called dactylitis, where there's swelling of the hands and the feet that can occur in young children with sickle cell disease that we don't see in adults. And again, that's due to the fact that kids have this red marrow that's producing blood cells. And so there's a hematopoietic stem cell that's produced. We're born with the number of stem cells that we're going to have for the rest of our lives, on the order of thousands. And these cells, are responsible for essentially creating all the different blood cells in our body. So white blood cells that help us fight infection, platelets that help us prevent us from bleeding, or as a patient when I was in fellowship at Emory told me, they're like inside Band-Aids. So I like to use that when describing them to families. And then what I consider to be the most important blood cell in the body, red blood cells, which millions and millions are created each day. And this is, because of the point mutations that's inherited from each parent that's found in the stem cell, you're only getting that abnormality of the sickle red cell in the red cells. And so that's where the problem arises. But as I'll point out, there's other players that in the pathophysiology of sickle cell disease that I'll show in a minute. So just a brief recap. So the kind of primary event or root cause of sickle cell disease is the single point mutation. that leads to a valine residue at the sixth position of the beta globin gene. It should be glutamic acid, so that changes the charge distribution across the beta globin, which impacts the ability of the hemoglobin to hold on to oxygen. And because of the decreased ability to hold on to oxygen under deoxygenated conditions, you get this hemoglobin S polymer that forms within the red cell that makes the characteristic Holly wreath or sickle red cell. So just kind of diving a little bit deeper, this is, these polymers that form inside of the red cell can disrupt normal cytoskeletal processes that occur in the red cell, making these cells very have decreased deformability. But because of the interaction of the polymer as well with the surface of the red cell, you get abnormal adhesion, protein expression on the surface of the red cell, as well as abnormal activity of water channels that are responsible for hydrating the red cell. So these cells are very, very dehydrated. That makes them very stiff, but also because of the impact on the expression of proteins on the surface of the red cell, they're very, very sticky and can stick to the endothelium. So these are just pictures of sickle red cells under electron micrograph and microscope, and what happens in the vessels because of the sickle red cell. So you get this kind of pathognomonic vaso-occlusive event that leads to the problems that we see. So there are other participants in the disease process, and the majority of what we think leads to complications in sickle cell occurs in the capillary bed and the post-capillary venule. So in addition to the red cells, we now know from decades of research that have gone on in labs across the country and world that there are other participants in the occlusion process. And so not only the red cells, but also white blood cells can interact with proteins expressed on the endothelium, including something called p-selectin, which will come up a little bit later in the talk. And then also these white cells can interact with red cells, and so you can get these white blood cell, red cell conglomerates, as well as white cell platelet conglomerates, red cell platelet conglomerates, and all of these things can lead to the vaso-occlusive process. But the other spectrum is the hemolytic process that occurs. Because these red cells are so stiff, they can be very fragile. And so the lifespan of a sickle red cell is about 14 days in the body compared to those of us without sickle cell disease. Our red cells are produced and stick around in circulation for about 90 days. And so there's a lot of hemolysis going on in the spilling of the guts inside of the red cell, including the heme that's a part of the hemoglobin, can lead to nitric oxide depletion, and that can lead to endothelial dysfunction and also contribute to the pathophysiology in sickle cell disease. And all of these together, we think, lead to the pain that we see in our sickle cell patients because of vaso-occlusion within certain, within the bones and the muscles. But there are lots of other complications. So really, no organ in the body is spared in sickle cell disease. And my mentor, Wally Smith up at VCU, who's a pain expert in sickle cell disease, uses a term, he uses the term hum. So after about 2 months of age, as the amount of fetal hemoglobin starts to go down and you start to recover from that nadir, as a baby, the humming of sickle cell disease begins. And so really that's when we think, although we may not see it in the first several years of life, that's when organ dysfunction really starts in these kids. And so there's a risk of stroke in our patients, and so we have to do screening for stroke between the ages of 2 to 16. The impact on the liver, gallstones because of the hemolytic process. The kidney is not spared, so about 40% of adults with sickle cell disease will have renal dysfunction. Priapism in men, avascular necrosis, the eyes, hearing, pulmonary hypertension, risk of septicemia because of the impact on the spleen, skin ulcers, and then all the pain that comes along with it. So it's because of all of these things that investigators are interested in finding drugs that can prevent all of these complications, but also extend the life in sickle cell disease. So back in the 1970s, another kind of historical correlate, the average survival of patients in the United States was in the teenage years. And again, now it's in the 40s to 50s, depending on who you read. So a lot of the improvement comes from the 1972 Sickle Cell Anemia Control Act under the Nixon administration. This is when kind of really the train started being pushed forward for newborn screening and counseling and doing a lot more investigation in sickle cell disease to improve the lives of these patients. So prior to this, there was no newborn screening. We didn't even know who had sickle cell disease. Well, I wasn't around then, but they didn't know who had sickle cell. In the 1980s, improvement in immunization practices, they did know at this time, the primary reason that patients died was because of sepsis, because of encapsulated organisms, and that was related to the splenic dysfunction. So improvement in immunization practices, initiation of penicillin prophylaxis led to the improvement in mortality. And then currently, the use of hydroxyurea, transfusions, and transplant is improving lives of patients. So now every state in the United States screens for sickle cell disease and other hemoglobinopathies after birth. This is just a Kaplan-Meier curve showing improvement in survival using various cohorts. So again, the bottom one is the earliest cohort from Jamaica in the 1970s, where you can see, many patients died prior to their 18th birthday. Going up to the most recent Dallas cohort that was reported back in 2010. So about 99% of patients with sickle cell disease were survived to the age of 18. And again, a lot of the improvement in survival has to do with these things shown on the right-hand side. So medications, but also counseling and newborn screening. So these are many of the standard therapies we use in sickle cell disease to help improve survival in our patients. So hydroxyurea, which we'll talk a little bit more about, increases the proportion of fetal hemoglobin that can reduce the stiffness and stickiness of red cells. We use red cell transfusions a lot in our patients to reduce the risk of stroke. If there is a risk of stroke that we find through doing something called transcranial Doppler screening. We also use transfusions for other reasons to maybe prevent, recurrent acute chest syndrome or recurrent pain. But that's definitely something we have in our arsenal to prevent complications in our patients. And then stem cell transplant. So about 3,000 patients in the US have now been transplanted. And gene therapy is coming out too, where we have probably about 50 patients in the United States that have gone through gene therapy. And we'll talk a little bit more about that. So even though we've done a lot to improve the lives of patients with sickle cell and improve mortality, we still have a lot to do. So this is from a study published in 2016, looking at about 12,000 patients with sickle cell in 2 states, Georgia and California. And what the authors did was look at mortality, shown here on the y-axis based on age range. And so the columns with the arrows pointing at them are patients with sickle cell disease. The columns in the middle are the African-American population for comparator's sake in those 2 states. And then the general population is the far right. And so what you can see is, even though we're improving mortality, we've got a long ways to go compared to the African-American population without sickle cell disease, as well as the general population. And what's interesting is we, even though we can get 99% of our patients to the age of 18, soon thereafter, the mortality starts really going up. And so there's a lot of research going into why this is in our adolescents and young adults. Some people think it has to do with biology. Some people think that it has to do with access to care. So lots of investigation going on in the area. So in order to think about improving the lives of our patients, we talk about clinical trials, and most people on the phone probably know this process, but just to review very quickly. So the process of getting a drug to market for patients in general usually takes about 10 years, and it starts with lab-based studies in the preclinical setting where you have to develop animal models to test your drug, into phase 1 studies, which 10, 20, 30 patients will be enrolled to look for safety measures. And these can be patients with the disease as well as people without the disease, so healthy subjects. And then once you're sure that your drug is going to be safe or feel very confident, then you can start enrolling for phase 2 or phase 3 trials, where much of the time the drug may be compared to a placebo. And typically these phases of studies will involve hundreds to thousands of patients. But this is how we think of developing targets for our patients with sickle cell disease. And just back to this slide again, just to remind you the various targets that that are being thought of as pharmaceutical companies and other developers of drugs are thinking or have thought over the years as the evolution of treatment paradigms have been changing for sickle cell disease are these different areas. And remember, I said the root cause of sickle cell disease, where it kind of all begins, right, is that inheritance of the two abnormal genes from parents. And so really the only curative therapy we have is stem cell transplant, but this is also where gene therapy works. And then there are drugs that are targeting the polymer formation in sickle cell disease, such as hydroxyurea as an example that can reduce the polymer formation within the red cell. But also those other types of players or contributors to disease pathophysiology that occur outside of the red cell is another area of investigation for various drugs that I'll talk about. So again, we think about this treatment pyramid. So at the very top is going to be that root cause of sickle cell disease, where that's kind of what leads to all the downstream problems that we see in our patients. So if we can target that root cause, then the thought is, we can help prevent all the complications that come or arise from that. And then beneath it are all the downstream sequelae that occur because of the hemolysis, activation of white cells, the battering and beating up of the endothelium, because sickle cell disease, at the end of the day, too, is a vasculopathy because of all the vaso-occlusion that's constantly going on, that humming that I talked about earlier, as well as depletion of nitric oxide. There's an impact on patients with sickle cell disease. We don't completely understand why, or at increased risk of having blood clots when they get older. So all of these things downstream as a consequence of the root cause. So there are drugs looking at targeting adhesion of white blood cells and red blood cells to the endothelium, reducing inflammation in the body, reducing how platelets may contribute to the pathophysiology, and then drugs that reduce oxidant stress inside and outside of the red cell as well. So first, just a little bit about stem cell transplant, and there's multiple sources for these stem cells. So peripheral blood mononuclear cells, so that's kind of mobilizing the cells and then taking them out of the bloodstream and saving them for allogeneic or auto transplant. You can get stem cells from the marrow, or you can get it from umbilical cord from a sibling. So allogeneic, again, just means getting stem cells from somebody else. We typically think of different ways of getting the stem cell source. So preferably a match-related donor. So somebody who's a complete match is the best way to go for curative therapy in our patients. And there's lots of different boxes that have to be checked when we're thinking about curative therapy and stem cell transplant. That's kind of beyond the scope of this talk. But there's also the match for unrelated, and then haploidentical is something that's being more and more investigated. So this is like a sibling or a parent, let's say a parent who's kind of what's called a half match. And we're finding that in centers that do a lot of these haploidentical transplants, the survival can be almost as good as a match-related donor, up to 90 to 95%. Although there are complications of GVHD and other complications from haploidentical donors that you don't necessarily get in match-related. So even though it's exciting to talk about curative options, there are side effects of getting the chemotherapy that patients have to get, including wiping out the immune system and increasing the risk of infection, as well as if you're getting somebody else's stem cells, you're going to increase the risk of something called graft versus host disease. The chemotherapy too can impact infertility. So even though it's best to try to transplant at very early ages, you increase that risk of infertility and that child not being able to have kids at a later age. So it's a serious discussion you have to have with family members. And then of course, the increased risk of death. Even though we're doing much better with transplants, it's still something that has to be considered if a kid's going to go to transplant. And as I said, the survival is best with a matched sibling. Dr. Kassow runs our transplant program here and does an amazing job with that. And just last month, actually, we did a matched sibling transplant here, as well as enrolled a patient in gene therapy. So exciting times here at UNC. So gene therapy is where you take the patient's own stem cells and you essentially take out the stem cells, you send them to a lab, and the lab puts in a gene therapy vector. So for sickle cell disease, you're not removing the sickle trait in sickle cell disease per se, so the two genetic abnormalities, although there are current studies that are investigating using that type of therapy, so something like CRISPR, but that's not it's not something that we've done here. The one that we are a part of from Bluebird Bio, you're actually putting in a hemoglobin A vector to try to get the patients down to almost like a sickle cell trait. And then you give the patient chemotherapy to kill off, replicating cells within the bone marrow to make space for these newly genetically edited stem cells, and you infuse them back into the patient. The first description of a patient with sickle cell who got gene therapy was out of France back in 2017. It was a young kid, I think 19 years old. And this is a graph of the patient months after the transduced CD34 positive cells. So these are the genetically edited stem cells, and you can see the hemoglobin concentration here. So the hemoglobin A is transfused hemoglobin from the patient. So as you can see over time, it starts to wane and go away. And then the genetically edited hemoglobin A that's put into the patient, there's a point mutation within the beta globin gene so that it can be readily identified in hemoglobin electrophoresis. Very, very smart. You can see after transduction that it starts to go up. And so over time, the patient almost becomes like a patient with sickle cell trait. And so this patient did very well. And as far as I know, continues to do well. As I said, the sponsor of the gene therapy trial that we're a part of is Bluebird Bio. We were allowed to enroll one patient, but there's plans for expansion in the future, hopefully, and then other trials may be coming down the road. So there is a potential for clinical cure, but it's not definite. There are certain complications that are coming about as investigators look into these 50 patients across the US that have gotten it. One patient developed leukemia and ended up passing away, and they think that was because of the chemotherapy that was given, the busulfan, which can increase the risk of secondary leukemia. So something that really needs to be taken into consideration. And you may see in the media all the happy stories that are going on, but it is there a lot of thought and discussion has to be taken before expanding this out to more and more patients. And then again, fertility I talked about as a side effect of the chemotherapy. All right, so what about most patients, right, that we have, they're not going to be able to get a curative therapy. Either they don't have a matched sibling or, they're not going to be able to be enrolled on a gene therapy trial because there's limited slots for this. And there's lots of exclusion criteria that may prohibit a patient from being enrolled. So so I'll talk about the targets within the red cell that are kind of coming down, coming through the pipeline for our patients. So, and these are the different areas, as I discussed earlier, that can be targeted. And this comes from a review article that I wrote with Dr. Little, who's the head of the adult program here. And even now, we wrote this a year ago. Even now, there's more and more drugs that have come out. So it's a really exciting time to be in sickle cell disease. So these are many of the drugs that have been trialed over the last 5 to 10 years or so. So from hemoglobin F inducers, of allosteric inhibitor of hemoglobin, the hemoglobin S to prevent the polymer formation, antioxidants, drugs that target hydration channels on the surface of the red cell to try to increase hydration within the red cell to reduce that polymer formation. I'm going to talk about the drugs that are FDA approved. So these 3 here, one kind of in each class. So Hydrea was approved in 1998 for adults, in 2017 for children. As I stated earlier, it increases fetal hemoglobin production and thus reduces polymer formation and stiffness and stickiness of the sickle red cells. We typically think of using this drug as prevention in children. We offer it about 9 months of age in every kid for prevention. And then we consider it in others for treatment if they're not started on it at 9 months of age. Interestingly, FDA approval is for 2 years and up, but based on other studies, we feel comfortable starting at 9 months of age, and that's kind of standard of care across the country. Some places in the country actually will start at 6 months of age. So we know with decades of experience in adults, as well as 20 years or so experience in kids, that the hydrea can decrease our pain in patients, risk of acute chest syndrome or pneumonia, decrease the need for transfusions, hospitalization, and now we're seeing that our patients actually, those adults that have been on it for a long time, live longer than patients that are not on hydrea. Downfalls include frequent blood draws because of the risk of impact on cytopenias in patients. Our patients have to get monthly blood draws to make sure that they're not developing cytopenias from the drug. And then we use caution in the types of sickle cell SC and S beta plus, just because these patients have an increased baseline hemoglobin already. And so if you increase hemoglobin levels in these patients, you could run the risk of developing vaso-occlusive problems in those patients, which we have seen in a handful of patients. So the next FDA-approved drug was Indari. It just got approved about 3 years ago. We're not entirely sure how this drug works. It's an amino acid, so L-glutamine. The thought is that the sickle red cell is starved of glutamine, which is important in the redox reactions within the red cells, and that the glutamine reduces inflammation and improves redox potential within the red cells. We think that's how it works. It was approved in 2017. Again, we think it reduces inflammation inside the red cell. And the data was based on a phase 3 randomized trial where patients were enrolled over the course of a year. Patients were randomized 2-to-1, drug to placebo. Patients had to be 5 or older and have at least 2 vaso-occlusive crisis events within the year prior. And being on hydroxyurea was actually okay to be enrolled in the study. And what they found, and this was reported in the New England Journal, was that patients that were started on the glutamine, and it's a weight-based drug, had on average 3 crises in a year compared to placebo 4. It doesn't seem like a lot, but it's a 25% reduction. And if you're a patient with sickle cell disease, that one reduction in crisis means a lot. They also found that there was a significant reduction in rates of hospitalizations in these patients, as well as acute chest syndrome. This was something that was submitted by one of our fellows to a conference last year. We did a retrospective analysis in patients, in 4 of our patients. This included adolescent and young adult patients that were started on Indari to see if it reduced the use of opioids, because we anecdotally thought that it was, and I've continued to see this in about, I have maybe 10 to 15 patients that are on this drug, and I continue to see this and hear this from patients and families. And so this was the amount of opioids in the dark box 4 months prior to starting Indari, and then the lighter box 4 months after. And you can see in every single patient, this patient went to not needing any opioids, a significant reduction in the amount of opioids that's needed. For whatever reason, it does seem like this drug works better in adolescent patients. So I don't know if there's an increase in inflammation within the red cells that occurs because of puberty and hormonal changes, but that is something that we think may be why it seems to impact these patients better. So I talked about this already. So it decreases the annual VOC, annual hospitalizations, may decrease acute chest syndrome. The main side effect we see is abdominal pain and constipation. It's not severe, but it can be disruptive in some patients, and I've had to stop the drug in a couple of patients. And then in the trial, there was an increased risk of having headache. Wasn't severe headache, but it was also seen in the placebo, so it's unclear whether or not it was the drug or something else that's just kind of happens in our patients with sickle cell. The next drug that was recently approved, actually 2 drugs were approved in November of 2019. Voxelotor was approved, and the results were published in the New England Journal just last year based on results from a phase 3 randomized trial. And so the way this drug works is, remember, hemoglobin is formed through 2 alpha globin subunits and 2 beta globin subunits. And it's the beta globin subunits that have that point mutation, right, that lead to that have the sickle mutation and lead to polymer formation. And so remember, if the hemoglobin gets rid of the oxygen, releases the oxygen, then that increases the risk of polymer formation within the red cell. So with this drug, it actually binds to the alpha globin subunit and kind of convinces the hemoglobin not to let go of the oxygen. And so, the theory was you could reduce the risk of hemolysis of red cells, but also increase the hemoglobin concentration because you're reducing the hemolysis. And so the company sponsored the HOPE trial, where 274 patients were enrolled, either get a high dose of 1,500 milligrams of voxelotor, low dose 900 milligrams, or placebo. Any type of sickle cell genotype were allowed to enroll. Patients had to be between 12 to 65 and have 1 to 10 vaso-occlusive crisis events the year prior. And so they assessed, and patients could not have a hemoglobin greater than 10.5 at baseline. And the primary endpoint was to look for a hemoglobin rise of 1 gram over the course of 24 weeks of being on the drug. And so what this drug is showing, kind of in the greenish line, the patients on the high dose, the bluish line, low dose, and then placebo. And so over the course of weeks, the change in the hemoglobin level from baseline. And you can see pretty rapidly in 2 weeks, the hemoglobin, they met their endpoint. It is pretty dramatic and pretty significant. And that was sustained over the course of the 24-week period. Although the 900 milligram dose didn't meet the endpoint of reaching a gram, it still was significantly higher than the placebo that you can see here, which essentially is just background noise. So again, 50% of patients reach that primary endpoint of having at least a gram increase from baseline, 33% in the 900 milligram or low dose, and then the background noise of the placebo shown here. So it's an oral medication. It's a big pill, so our pediatric patients may have difficulty swallowing, although the company is looking into a liquid formulation for patients. It increases hemoglobin, and we're learning that actually patients that are put on this drug seem to have increased energy, which is important in our patients. It does reduce the markers of hemolysis, so our patients can come in and they don't have as much scleroicterus as they used to have. Their reticulocyte count goes down. In the initial trial, they didn't look at the impact on the number of vaso-occlusive crises, although there was a poster presentation earlier this year at the European Hematology Association that showed that patients that were on voxelotor had a reduced number of vaso-occlusive crises when they were on the drug compared to the placebo. So it's interesting. The way that the drug binds to the alpha globin, we can't reliably get a hemoglobin electrophoresis on our patients. It shows up as a weird spike in the hemoglobin electrophoresis. So if you want to get a reliable electrophoresis on our patients, which again is important to look at, the amount of sickle hemoglobin versus other hemoglobin, you actually have to stop the drug 2 to 4 weeks prior to doing the electrophoresis. And so that's a downfall. Side effects include headache, abdominal pain, which is real. If that occurs, we usually will reduce the dose to 1,000 milligrams from 15. There are currently phase 1/2 studies that are going on in younger patients. So the HOPE Kids 1 study data should be coming out as young as 9 months of age. Data has come out and seems to be promising for these patients. And there's a HOPE Kids 2 trial that's looking at the impact of this drug on TCD, transcranial Doppler, which we use for stroke screening. So some people think that it may actually reduce the risk of stroke. So next we're going to talk just about targets outside of the red cell. So remember, outside the red cell are targeting kind of these things that are spilled out into the bloodstream because of hemolysis in sickle cell, but also drugs that may impact the sickle red cells adhesion to endothelium, which, remember this picture that I showed earlier in the talk, there are drugs that can not only impact the red cells propensity to sticking, but also the white cells that we think can contribute to the vaso-occlusion. And so here are some examples of drugs that have been trialed or are in trial. So drugs that target endothelial adhesion. Some drugs may sound familiar to you. So IVIG is being actively investigated to see if you can reduce adhesion of white blood cells. Propranolol, a beta blocker. There are drugs that are looking to impact vascular tone, so arginine, citrulline, so amino acids. Statins have been trialed, but to negative effect. Platelet inhibitors as well have been trialed, but to negative effect in patients. But we'll go over the one FDA-approved drug, crizanlizumab. And so the results from this trial actually was published by Kenataga, who was the head of the adult sickle cell program here at UNC up until 2018. He ran this trial in crizanlizumab for the prevention of pain crisis in sickle cell. So it was approved in November 2019. It's a monoclonal antibody to P-selectin, so IgG, to P-selectin, which sits on the surface of endothelial cells, as well as on white blood cells. And so we think it kind of, acts like a mask in a way. So the antibody kind of inhibits the interaction of the sickle red cells with the P-selectin that may be on the surface of endothelial cells to help reduce the vaso-occlusive process. And so the FDA approval came from results of the SUSTAIN trial. I can't remember what that stands for, but it was a phase 2 trial where patients were started on this drug and kept on this drug over a year. It's a monthly infusion. So 100 and almost 200 patients were enrolled and divided between a high dose, low dose, or placebo. The approval is for patients 16 to 65. And for the trial, they had to have at least 2 to 10 vaso-occlusive crises in the year prior. Hydrea was okay, but patients could not be on regular blood transfusions, thinking that that would impact, the interpretation of the results in the study. So the primary outcome was looking at the annual rate of pain crises over the course of 52 weeks. And sure enough, patients that were enrolled, I don't know what a 0.63 pain crisis is, but you can see compared to placebo, it's about a 50% reduction in patients that got the crizanlizumab high dose, and then a reduction from 3 to 2 over the course of a year in the low dose. So what this cumulative event rate plot is showing the time to first sickle cell related crisis, right? And so what I've drawn here is that 50% of people that were placed in the placebo had at least a crisis after being enrolled for just over a month. Patients that were on the low dose crizanlizumab, which was not statistically significant compared to placebo, they got their first crisis just after 2 months. And then you double that. So patients on the high dose, 50% didn't experience their first crisis until 4 months after. So an elongation of time to first crisis was what they show here. And that's also shown in this plot. But also they looked at the second crisis. So the second time the patients came in for medical care because of a crisis, the second crisis took 10 months in patients with sickle cell disease that were enrolled on the drug versus in placebo, it was only 5 months. So again, a significant impact on the pain in patients that were enrolled in the trial. So again, it's an IV medication given monthly, can improve pain and hospitalizations. Adverse effects that we have seen actually are a little bit of nausea during infusion. It's a 30 to 60 minute infusion, as well as back pain, which we don't completely understand. There are studies that are ongoing looking at the impact of crizanlizumab on other end organ outcomes, including priapism, so that's the Spartan trial, and then also on nephropathy or kidney outcomes in adolescents and in young adults with sickle cell. So trying to see if this P-selectin inhibitor can reduce end organ damage in these trials. So in conclusion, sickle cell disease pathophysiology is much more complex than, what we thought it was in 1910, 1949, even in 2000. So there's lots of different players now that can be targeted in sickle cell disease to try to reduce complications. The future is very bright for drug discovery and development, and many, many therapies, hopefully, that I've gotten across are being trialed in both kids and adults with sickle cell, and others are on the horizon. And we're starting in sickle cell disease as providers to think of a multimodal approach to treatment. So, all these different drugs that we have in our toolbox, almost like, using chemotherapy to treat cancer in oncology, trying to target the different mechanisms, either the root cause or the polymerization process or, the hemolytic process and occlusive process that goes outside of the red cell. So thank you very much. This is a list of all of our providers in our pediatric hemonc group here at UNC, and I look forward to taking any questions that you may have.
Hi, Dr. Carden. This is Marie Ambrose Thigpen. Thank you so much for that talk. I have a question.
Sure.
I wanted to know, what is the length of time that someone usually has to wait to get a transplant if they're going to get one? Because I know for other transplants, there seems to be a little bit of a dearth in the people of color signing up
Yeah.
for transplant registry. So I'm just curious for bone marrow, how long do you normally see kids or adults have to wait?
Yeah, that's a great question. Let me just say something that I wanted to say during the talk that I didn't. So there's no FDA approved. So, the primary reason that we see kids and adults come into the emergency room for pain crises is because of pain. There are no FDA approved drugs, and there have been no studies to show any drug that can eliminate pain in our patients with sickle cell disease during crisis. So that's why we have IV fluids and opioids and pain medications when they come to the ER, and that's really all we can use. The other thing to think about in vaso-occlusive crisis is most of our patients, over 50% of our patients, they will stay at home for days in crisis before presenting to the ER. So part of the crisis process that's going on has already worked its way out before they came to the ER. And some of that has to do with, trying to treat it at home, but also some of the stigma that comes with, that we do see, in some places when treating our patients with sickle cell disease. So I did want to say that, and I meant to say that. But back to your question, Dr. Thigpen. So yes, there is a because most of the people that are in the registry, and this would be a better question for Kim Cassow to answer, but I'll try to take a stab at it. For most of the patients that are in the registry, the CIB, NTR, who, these are people in the world that have been generous to say, hey, look, I'll donate for a transplant if, there's a match out there and somebody needs it. I think, most of them are Caucasian or not of African descent or of color, which most of our patients in the United States with sickle cell disease are. And so that's why there's a dearth um, of opportunities if you don't have a matched sibling. So the best outcome in patients with sickle cell disease with respect to transplant, as I talked about, is a matched sibling. And so if two parents, get together and they have a kid with sickle cell and they decide to have another child, that the chance of having a child that's an HLA match is going to be 25%. And so oftentimes, there's not a match. Um, we're we as a community are talking more and more. The older studies enrolled patients with sickle cell that had, quote, severe disease. So history of stroke, recurrent acute chest, multiple pain crises a year. We as a community are starting to question whether or not, we should just transplant even people that don't have a lot of complications as children. Should we consider curative options for them earlier on before they develop all those complications? And that's something that's ongoing and kind of dependent institution to institution. But if there is a matched sibling donor and our transplant colleagues think that they qualify for a transplant and the sibling is of age, I think 2 years or older to be able to donate stem cells. And there's lots of ethical questions there about, having a 2-year-old donate stem cells to cure a sibling. But typically they can get things going within 2 to 3 months for a cure. We have several patients who are going to be on the docket over the next 3 months or so to go in for a matched sibling donor transplant here at UNC. And I can tell you, our transplant team is working very hard to try to get them in, especially with the limitations of COVID and making sure that, there's no increased risk of them getting COVID during transplant because of the impact on, the immune system. So the other option for transplant is haploidentical transplant. And so because there's, more people are kind of going away from using a match unrelated donor to a haploidentical donor. And that's again where you have a parent or a sibling that's a half match that could be used for curative options. And it may take a little bit longer for those patients who are going to get a haplo to be enrolled and to go to transplant. That's much more kind of investigational. I mean, we've been doing matched sibling donor transplants for decades now. The haploidentical transplant data has really only been, I think, over the last 5 to 10 years. So there's only certain centers that will do it, and most of the centers that will do it only will do it if the kid is on study, because we learned so much from putting patients on clinical trials. So does that answer your question and then some? Hopefully.
Yes, thank you very much.
Sure. Yeah, great question.
Are there any other questions for Dr. Carden? I guess there isn't. I wanted to just take a quick moment to everybody. Sorry I was late. I just wanted to make sure that you saw Davina's email looking for leadership in our department. I hope you will all consider serving in this manner. We did not have any nominations. We had hoped to have elections this time, but please consider, especially our community pediatricians, consider serving in this manner in our department as vice chair. And if there are no further questions for Dr. Carden, thank you so much for joining us this morning. That was really wonderful. Appreciate it.
Thank you. I'll put my email in the chat if anybody has any questions or anything, if you think of anything afterwards, feel free to email.